The department had good staff, experienced nurses, board-certified attendings, functional equipment. Every process on paper was sound. And then it was a bad day, and things went wrong that shouldn't have. The instinct after a bad day is to find the individual failure. Who missed what? What protocol wasn't followed? But that instinct almost always points in the wrong direction. Hello, my name is Chet Shermer, and I've been practicing emergency medicine for 25 years in both community and academic settings, from small rural 4-bed emergency departments to 30-bed community hospitals and 60-bed tertiary care academic medical centers. I have seen successes and failures at all levels. Let's learn more to prevent these failures. Emergency departments are nonlinear systems. That means a small increase in input, more patients, higher acuity, a few extra complex cases does not produce a proportionally small increase in strain. It produces a disproportionately large degradation in performance. This is not intuitive. We think in linear terms. If a 20-patient census works fine, a 24-patient census should work almost fine. In a linear system, that would be true. Emergency departments are not linear systems. At a certain census threshold, communication degrades. Task prioritization becomes reactive rather than proactive. The margin for error that exists at normal census disappears, and the system becomes brittle. This is not a personal failure. This is physics applied to human operational systems. The first mechanism is boarding amplification. When admitted patients occupy ED beds, the physical capacity of the department shrinks. 4 boarders in a 12-bed department means you are operating a de facto 8-bed department while managing the patient load of a 12-bed unit. Nurses are still responsible for those 4 boarders: documentation, medication administration, family communication, deterioration monitoring. That nursing time is not available to new patients arriving through the door. Physicians are managing a full census of active patients, plus monitoring admitted patients whose care plans should be in inpatient hands. The cognitive load is not halved. It is compressed into the same mental bandwidth. At a certain threshold, something gets missed, not because someone was careless, because the system was operating outside its design parameters. The second mechanism is acuity compression. As physical capacity fills, triage becomes reactive. Patients who should receive rapid assessment wait because there is no room to put them and no provider available to see them. Triage categories get reinterpreted under pressure. A level 2 arrives, chest pain with diaphoresis, but all beds are full. The charge nurse makes a clinical call to hold in triage. That patient waits 20 minutes before anyone can lay hands on them. In 20 minutes with an anterior STEMI, those minutes are myocardium. This is not about one decision. It is about a system that has pushed past the threshold where good decisions are reliably possible. The third mechanism is cognitive overload. Emergency medicine is built on pattern recognition. You are constantly running parallel streams of clinical reasoning across multiple patients simultaneously. When census and acuity exceed the system's design capacity, that parallel processing degrades. Interruptions increase. Each interruption breaks a cognitive thread that takes time and energy to rebuild. Research on cognitive load in high-stakes environments is unambiguous. Performance degrades under conditions of overload, even in expert practitioners. The expert doesn't become immune to cognitive saturation. They just hit the ceiling later than a novice. Departments that manage bad days better share specific characteristics. They have surge protocols that trigger before the system reaches its breaking point, not after. They maintain cross-trained staff who can flex functions under pressure, and they have honest leadership that acknowledges when the department is operating at or above threshold. Critically, they have cultures where raising a concern about system capacity is normalized rather than stigmatized, where a charge nurse can say, "We're at the wall," and that triggers a system-level response, not an expectation to push through. The worst days happen in departments where the message is, "We'll figure it out." The better days happen where the message is, "We see what's coming, and here's the plan." 3 things to carry from this brief. First, when something goes wrong on a bad day, the investigation needs to include system state, not just individual actions. What was the census? What was the boarding count? What was nursing ratio at the time of the event? Second, bad days are predictable. If you track the variables that correlate with system strain, you can see them coming. Demand that data. Third, Advocating for operational safety is clinical advocacy. The physician who pushes back on unsafe census conditions is doing the same work as the physician who refuses to discharge a patient who isn't ready. Own that role. This is Global MedOps Command, Clinical Brief Series. Good departments fail on bad days because they are complex systems operating under conditions they were never designed to handle. Understanding the mechanism is not an excuse. It is the precondition for fixing it. Next brief. Why transfers break down even when everyone follows the rules. Stay prepared. Stay educated. Out.